Sure. Thank you so much for the kind introductions, and thank you very much for the invitation as well. I will share my screen. Just let me know whether you can see my slides. Can you see the slides now?
Yes.
Yes.
Excellent. Okay. Well, again, thank you very much. I've got about 30 minutes or so to take you through the topic. So I'm going to talk about impact of COVID-19 on ethnic minority communities. So for this presentation, I'm going to go through pre-pandemic equalities or inequalities, epidemiology of COVID-19, and this is where we have most of the data. There's been a plethora of work that's been done in this. Possibly some work on potential mechanisms for disparities, some recommendations which are quite wide and more so I know because of this is RDS, a little touch on research in ethnic minority populations. I'm more than happy to discuss about the research aspects of how we do research from our center, the Center for Ethnic Health. In terms of pre-pandemic inequalities, these are the areas that we do have inequalities, and we have enough data on this by poverty, socioeconomic deprivation, health, wealth, opportunities, illiteracy. And these are really, and Marmot, as you know, is the advocate and has been championing this for many, many years. These are the social determinants, and we really need to address the social determinants to reduce these inequalities. Just to go through in terms of ethnic minority groups, what the differences are which may have impacted COVID-19. So this is looking at the proportion of households with at least one person aged more than 70 years of age in the UK in 2019. As you can see on the left-hand column here is those over under 70, contain only those over 70. And usually you'd see that the white population have about 75% who live on their own when they're aged over 70, less so with the other ethnic minority communities. But when we go on the right-hand side, this is the interesting data, multi-generational households. So someone who is aged 0 to 19, 20 to 69, and somebody aged 70 and over living together. And here we see it's the Bangladeshi and the Pakistani population who have a lot more people living in multi-generation households. And this is data, similar data looking at from the ONS, and this is Vahe, who worked with us on this COVID publication. And what we see here is Pakistani and the Bangladeshi in the multi-generational households with a child at the bottom in the blue, and those with multi-generational households in the green. And again, what you see, it's the ethnic minorities who are more in not just multi-generational households, but also in multi-generational households with with a child as well. And a few there with more than 3 adults living together. Pre-pandemic, if you look at the percentage of ethnic groups living in the 10 most deprived neighborhoods in England in 2009, and again, what we see is at the right-hand side, the ethnic minority communities, Pakistanis, Bangladeshis, Black populations. On the left-hand side, what we see is the Indian population here. You see, although they may live in multi-generational housing, they live in less deprived populations. This is proportion of people having healthy eating, fruit and vegetable, the recommended fruit and vegetables per day. And again, what we see here is it's the Asians and the Black communities who are significantly less than the white British population. Employment, again, we see disparities in employment. This is people aged 16 to 64. Both in males and females. We see the ethnic minorities overall are less likely to be in employment. I think this is a really important key slide. And this is the vulnerability to infections. And this is not just COVID, but any infections. This is looking at share of key workers among working age in the 7 ethnic minority groups. And this is in the light green is the health and social care, and the dark green other key workers. And if you look at Black Africans, high proportion of health and social care, and this is mainly driven by people working in the nursing environment, and also other key workers as well. And this compares much higher than the white British communities. So we can talk about this later on, about what are the key factors leading to people being affected. But if you look at health and social care, again, it's Blacks and the South Asians who tend to be working more in these environments compared to the white population. And finally, looking at the self-reported long-term health by different ethnic groups. And this is a question on someone who has more of a chest, breathing problems, heart problems, blood pressure, circulatory problems, and diabetes as well, a very broad question. And what we see here overall compared to the white population as the reference standard, in majority of the ethnic minority populations aged 45 and over, you get much poorer health in ethnic minority populations. So that's all pre-pandemic. So what's happened during the pandemic? My life changed a lot on the 1st of April, 2020. Prior to that, as Jörg knows, my area of work has been in cardiometabolic diabetes, cardiovascular disease, but also working in the ethnic area in those conditions. And this is a tweet I sent out on the 1st of April, 2020. And this was because a few from my friends who were working in hospitals and intensive care phoned me and said, Kamlesh, you do research. We're seeing a lot more Asians and Blacks coming into intensive care unit compared to what we would normally see for our population. So I sent this tweet out on the 1st of April and said, can people share their experience quickly? And I had a few trolls saying I was scaremongering at the time. We hadn't had any signals such as this prior to this from the US or obviously where we'd had the larger proportions affected, such as Spain, Italy, and China. And then 3 days later, the ICNARC report came out. This is the intensive care unit data showing that indeed there were more people from ethnic minority populations who were admitted with COVID-19 in hospital. And this was about 35% were non-white compared to the 2011 census of 13% at the population level being non-white. And since then, there's been, as I said, a plethora of publications. This is something that we did quite early on, looking at the whole of the English population, 61 million people database, and looked at deaths with COVID-19 in England, adjusting for age, sex, deprivation, diabetes status and region. And what we see here is that overall the risk was increased in Asians by about 1.3 to 1.4 fold, and in Black communities by about 1.7. So this is probably the largest study, I think, so far that's reported this. This is then I worked with Open Safely on data, Rohini Mathur, who is the lead author, and this paper should be coming out tomorrow in a high impact journal. It is on medRxiv already. And this is looking at a population of about 13 million. And this is, first of all, is looking at being tested positive for, being tested for COVID-19. And what you see here is compared to the reference population of white on the right-hand side, minority ethnic health populations were more likely to have a test done. But this was probably because they were being tested more. There was a lot more testing in those areas. I know Leicester, we haven't come out of the lockdown. We've had some restrictions all the way through from the first wave. Then looking at the data of being tested positive for COVID-19. And again, what we see here is that all ethnic minority populations are about 50 to 90% more likely to have a positive test compared to the reference white population. Then the association between ethnicity and intensive care unit admission. And again, we see 2 to 3-fold increased association for ethnic minorities for intensive care population. And then when we come to deaths associated with COVID-19, and we see about a 30 to 40% increased risk associated with deaths due to COVID-19 compared to the white population. And this is at whole population, not just hospitalized patients. If you look at the hospitalized patients, most of the data that are coming out seem to be very reassuring, that although more patients are admitted to hospital, the mortality rates seem to be very similar across different ethnic groups. This is looking at association between ethnicity and non-COVID deaths. And here what we saw on the PHE data, that overall there were lower deaths in ethnic minority populations. So we've brought all this together, and one of our fellows in our team with Manish Parekh, who works with me, they conducted a systematic review of 18 million people, 50 studies. And here we see a majority of the data were coming from the US and the UK. So risk of COVID-19 increased, as you can see at the top, in Asians, Blacks, and Hispanics, and overall 73% increased association with ethnic minorities having COVID. Looking at COVID-19 in ICU admissions compared to the white populations, and we see a significantly increased association for Asians, a 2-fold increased association, but the number of publications was very small. For Black populations, not increased, and for other populations, not increased. And then when we come to mortality, overall, a 22% just missing significance for Asians, but no increased risk with others. So these are quite reassuring that mortality overall doesn't seem to have been higher in ethnic minorities. Although they get more infections, they're more likely to go to intensive care unit. And looking at some of the reasons for this, this is early data we looked at, and there's now a lot of data, but very little data by ethnic minority populations. We should have some data soon looking at the whole of the English database by ethnicity. And this we looked at Biobank of the association of BMI with confirmed COVID-19. On the left-hand side, you can see the spline graphs for body mass index at the bottom and the odds ratios, and we see increased odds in ethnic minority groups, but not so in the white group. On the right-hand side, we see the odds ratio of ethnic minority compared to the white European population, and we see the risk increases from a BMI of 26 onwards. And there may be reasons for this. We know obesity is a risk factor for COVID-19 and severe COVID and mortality as well. And some of this is due to the pathophysiological mechanisms, how COVID attacks the organs with increased cytokine storm. And if people have obesity, they already have heightened inflammatory markers. And it may be that COVID is making this worse. This is ONS data. We looked at this for the SAGE committee. Vahe, again, working with us from the ONS, looked at the contribution of multi-generational household. And if this analysis showed that overall multi-generational household explained about 10 to 15% of the increased risk of deaths, especially in females and people of South Asian background. What we've shown also, which is in a different analysis, is that from the first to the second wave, there have been reductions and disparities for the Blacks. So there is no increased association of Blacks compared to the white population in terms of COVID in the second wave, but the risk seems to have increased for Bangladeshis and Pakistanis, but less so for Indians. And this, we think, is because of the multi-generation households, and that may be explaining. And this is certainly showing that, as you can see, the females here on the right-hand side, Bangladeshi Black African, Black Caribbean, Indians, Pakistanis, there is increased association with both socioeconomic factors and multi-generational factors as well. But a lot of this seems to be driven by deprivation. This is a paper that just came out today. This is from Alex Rowland from our team looking at biobank. And here the question was, is shift work associated with getting COVID and severe COVID? This was hospitalization or death. So we compared people who weren't healthcare workers or shift workers or both. And what you see is that overall shift work is associated with worse outcomes for whites and ethnic minority groups. But if you're a healthcare worker, your risk is increased hugely, similar to a shift worker. But if you're a shift worker and a healthcare worker, then as you can see here, the risks are anything from 7 to 11-fold higher, 11-fold higher for Black populations, which are significant, about 9 times higher for South Asians and 7 times higher for white populations. And this really seems to be similar to what we then see in conversion to seropositivity. So this is a study. We looked at a large tertiary hospital in Leicester, 10,000 hospital care staff. And what we found here was about 10% were seropositive. And this was probably about 4 to 6 months ago. And again, what we see is South Asians and Blacks, they were significantly more likely to be seropositive. So they would have had an infection. And the highest prevalences were in people who worked in ED, nurses, healthcare assistants, people from more deprived areas, and the younger healthcare workers, particularly younger doctors as well. As expected, anesthetists and intensive care unit staff had much lower seropositivity, which has been shown in terms of mortality rates in this population. And this shows that if you do have full PPE cover, which obviously they have to use in anesthetics and intensive care, that you're less likely to get COVID. Potential mechanisms, well, it's a really complex area. I don't think anyone could explain that there are 1 or 2 reasons for these disparities. This is Vital, who worked with us, and this again just came out last week, looking at a framework of understanding pathways underpinning ethnic inequalities. So this could be because of differential exposure, differential vulnerability, differential disease consequences because of comorbidities, differential social consequences because of working conditions, differential effectiveness of control measures, and this could be resources, vaccine hesitancy, languages, and then this differential adverse consequences of control measures, such as due to unemployment, working condition, access to social protection, stigmatization, etc. This is something we did in the ONS analysis, showing that all of these are risk factors, and we haven't got work conditions here. But what we saw is in the solid rectangles are what we observed: the underlying health, overcrowding, household composition, deprivation, ethnicity, and age being risk factors for COVID deaths. But the others we didn't observe in that study was things like cultural factors, behavioral factors, which are really difficult to measure. But I've shown you that we could add shift work to this, and obviously key worker status as well. Recommendations to reduce disparities. Well, this is something Dan from ONS working with our group did, that lockdowns work. So what we see here is the green bars are pre-lockdown period of being positive. Sorry, this is for deaths, and yellow bars are post-lockdown. As you can see, reduced rates following lockdown. So lockdowns certainly work in all ethnic minority populations. Vaccination is an important aspect. We know they work, but there is huge amount of vaccine hesitancy, and these are some of the barriers among ethnic minority populations. The trust is coming regularly in the work we've done and others have done. Inconvenience in terms of access barriers. The perception of risks seems to be slightly different. And then there are other aspects such as educational level, household decision. The key person who makes the decision in the household also makes the decisions for the rest of the family. And I think healthcare workers, when there's hesitancy there, that's going to go into the community. And that's something I know the government and many of us are trying to overcome. But vaccine hesitancy is not new. It's not just due to COVID. So this is some work we've done with the Q Research database with Julia Hipsley Cox. And here looking at flu vaccine uptake. And we see that flu vaccine uptake is higher in Bangladeshi. And the reason for this, we think, is because most of the Bangladeshis in Q Research are in East End of London. And the East End of London Public Health and Primary Care have worked very, very hard over the years to improve outcomes for their populations. We think this is what's driving the increased flu vaccine uptake in the East End among the Bangladeshi population. But then when we come to the Pakistani populations, African Caribbean do have the largest vaccine hesitancy during the COVID pandemic. But also this has been shown pre-pandemic in influenza as well. And what we see at the bottom is household size also is associated. Larger the household, the less likelihood that they will take up flu vaccination pre-pandemic. And there's been a number of surveys. This is Understanding Society survey, and this was conducted in November, 11,000 participants, showing if you just concentrate on the pink bars, there were unlikely or very unlikely to take up the vaccine, 70% among Blacks, 42% among Asians, compared to 15% among the white. Fortunately, we've seen the vaccine uptake has improved dramatically over the last few weeks, but there is this disparity that ethnic minorities are still less likely to take up the vaccine. In terms of recommendations, we worked with the South Asian Health Foundation. I'm a trustee on that, and a number of us worked on this publication looking at all ethnic minority groups. And some of the slides I've shown you are in there. This is downloadable free of charge in terms of the report. And we came out with some recommendations, which probably hold still true now as well. We had some interesting infographics. Again, all of these are available from the South Asian Health Foundation website. And we've translated this into, I think, 5 or 6 different languages now. And people outside of the UK have asked us permission to use these, but they are freely downloadable. If they're helpful, please download them. And as I said, these are in different languages for your communities. We talked about short-term actions such as culturally tailored public health messaging, tailored test, trace, isolation programs, priority testing, and some of these have occurred. Mandatory occupational risk assessment in healthcare settings, certainly this has taken off. BMA has been working very hard, but we're still hearing that people of minority ethnic health backgrounds still haven't had a risk assessment done. We're very keen that, and especially for this audience today, RDS, that research on quality and equality is conducted not just during the pandemic, but when we come out of it. We need to protect the migrants. We need to close the educational gaps, and certainly these have increased, especially for the deprived populations and minority children, and we need to strengthen the science. Tailored health communication, and I know a number of people, I'm sure they're sitting here watching, have worked tirelessly to get the health messages out to their communities. I know of many organizations that are using culturally accessible tailored messages through all sorts of channels of communication. And they will have reached, there's some data showing that they have changed behavior, but there is importance of trust and leadership. When you speak to people, qualitative studies, they say they trust the leaders within their communities, they trust the faith community leaders, etc. And that's the areas that we need to work with. But one thing is really important. There has been a lot of confusing messaging. We need to avoid this confusion in terms of multiple guidelines messaging. And particularly, we need to caution against stigma that certain populations may get, even, for example, if they don't want to take up the vaccine. I think it's something that we need to work with our population to try and change their behavior rather than stigmatize them. Whole lot of long-term actions. These are not rocket science. All of you know all these: improving social security, housing, improving educational achievements, addressing discrimination at all levels, and improving health literacy and lifestyle behavior educations. Overall, really reducing inequalities in all the groups that have been affected by the pandemic. This was the risk reduction framework I was asked to chair by NHS England. And this has been, as I said, used in over, I heard at last about 1.5 million, but there are still huge numbers of populations who haven't had the risk assessment done. I think this is a key analysis, and I should have put a reference to this. This is Tom Yates from our group who's done that analysis, and they did mediation analysis looking at the biobank and to the degree to which the excess risk of COVID-19 outcomes can be eliminated in ethnic minority population. If we move them in terms of the most deprived 25% or the most deprived 50% in the whole population, and they are moved out of deprivation. So if we look at left-hand side is COVID positivity, in the middle having severe COVID, and on the right having mortality. And what we see is if we move people from the 25 most deprived target to not being in the deprived areas, we reduce the risk for positive COVID severity and mortality by 40 to 50%. If we eliminate and reduce it by 50% in terms of deprivation, getting people out from the 50 most deprived areas, then we near enough eliminate this disparities that we've seen. And so this is a word of caution, this is modeling study. Finally, into research in ethnic minority populations, our data that are being collected inclusive, and this is a systematic review that we conducted, because we're seeing that data on ethnicity are still limited in published medical literature. Most trials aren't collecting not just ethnicity, but many of the protected characteristics, even just age and sex. And in this systematic review, we found on clinicaltrials.gov of data or studies ongoing on COVID, only 6 of these studies on clinicaltrials.gov mentioned that they were collecting data on ethnicity. I think things have changed a lot. NIHR, I must say, have done a tremendous job. They've been working with our Center for Ethnic Health, trying to get people not only to collect data on ethnicity, but trying to promote research within ethnic minority communities as well. And overall, we do need to improve that. This is Sean Trevick in Aberdeen, who's doing some excellent work. And myself and a few others wrote this editorial in The Lancet that really to improve involvement of ethnic minority groups in research, we need to think about the participants' ethnicities when designing a stage, really. And then obviously reporting should become as routine as thinking about reporting data on age and sex. And researchers, research funders, public health and policy agencies all have a really duty to ensure that we have representation from the whole community, not part of the community. And there are a number of resources at the bottom you see that include framework. And again, this is ongoing work, and Sean is leading on this work. The website is at the bottom. We from the Ethnic Minority Center have developed a toolkit of how one can increase participation in research, health and social care research among ethnic minority groups. And again, these are downloadable from the website you see above. So in summary, we've seen huge disparities. What we do know, and this is again, this infographic is available from the South Asian website, And this we did early on in the pandemic, but I don't think things have changed much. So in the green circles, we see where the disparities have occurred. This is where we have really good evidence. People with comorbidities, ethnic minority populations, males, people from deprived areas, elderly, and those with obesity have been affected the most. If we look at the orange bars, these are limited evidence looking at occupation, housing, lifestyle, environmental pollution, genetics. They have certainly contributed, and a lot of this has been done through modeling studies. Blue bars, indirect evidence, looking at behaviors and structural discrimination. We don't know about the evidence. I've caused a lot of controversy by putting this, by saying vitamin D. We don't have much data yet. There is some data now looking at large data sets, but there, as you know, lots of confounders are there, but there are ongoing vitamin D trials, so we await those trials. So in summary, there's growing evidence of ethnic disparities and inequalities. There's increased risk of infection, increased risk of hospitalization and intensive care unit admission, increased risk of deaths, but the disparities in deaths are not so severe when people are admitted to hospital. There are no single explanations, and social inequalities, structural factors, such as deprivation are likely to play a major role. And to overcome this, we really need a multi-sectoral approach, but we need policy actions to reduce these inequalities. And for research, we do really need to up our research during the pandemic, after we come out of it, and ethnicity coding is going to be really vital for this. Thank you very much for listening.
Thank you.
We can't hear you, Joe.
Again, yeah, many thanks for this excellent and really very comprehensive talk. So it's obviously that you have huge amount of data now amassed, and I think understanding has improved a lot. I assume you are happy to take some questions, Kamlesh?
Of course, yes.